So I'm a doctor. I became a doctor sort of 35 years ago or so. So that's what I did first of all. I did medicine. I think just thinking forward into one of the most exciting moments, I think one of the most exciting moments was when I discovered that I really liked working in sexual and reproductive health. And that was really after about 5 or 6 years of being qualified as a doctor. And I wasn't quite sure what I wanted to do, but I'd done a whole load of different hospital jobs and nothing had really excited me. I didn't particularly like the hospital environment. And then as part of a rotation, I went into the community and I worked in some very socially and economically deprived areas in West London, which is where I come from. And I worked in a community-based sexual and reproductive health clinic for young people. And I suddenly realized that that was what I wanted to do. And I often think, why do I like it? And why did I find that so exciting? And I'm not really sure of the answer to that completely, but I think you feel you're actually providing, it's fantastic. I was working in a service that functioned well and provided a really good service. And that is really empowering because at my age, I've worked in lots of different services. And sometimes when you work in services that aren't very functional, it's not a particularly rewarding or empowering environment to work in. But this clinic that I worked in was seeing very marginalised young Black girls, mainly from West London, who were really at high risk of unplanned pregnancies and STIs. And I felt really empowered in there because I felt I was able to offer them something, offer them a service, help them in a very basic way. And I saw that there was a need there. And that's what I really enjoyed doing. And I enjoyed becoming really skilled in that area and being able to engage with these people and often to provide a decent service. So I think that's been the most exciting aspect of my career, really. And then since then, I've really specialised in that area over the last sort of 25 years or so. I later on, after doing a lot of sort of professional qualifications, I later on did a Master's of Public Health because I realised the overlap between clinical medicine and public health in sexual and reproductive health. And as opposed to just dealing with people on a one-to-one basis, I like and I'm interested in, and I wanted to understand how we could provide an environment which was healthier for young people to grow up in with regards to their sexual and reproductive health. So that was really what drew me into public health. And then after having done my Master's of Public Health, and I've done a lot of teaching along the way, I've done a lot of clinical teaching, particularly to more junior doctors and things. I realized that education was providing education was as rewarding and interesting as providing clinical services, really. And I still think that's what I get the most buzz from in many ways, is when I have a lot of students, and they're master's students, sort of graduate students now. They're not clinicians necessarily, but often they're being introduced to sexual and reproductive health for the first time. And a lot of them get really inspired by that and want to work in that and want to go on and have a career in that area. And they're really young, bright, interested things who, it's fantastic to be surrounded by young students like that. And, you can spot a lot of them who are going to go on and do great things in the sexual and reproductive health field. So that's very rewarding. And I've sort of, since the last 10 or 15 years, I've sort of combined teaching and clinical work, but teaching now mainly in public health with a little bit of clinical teaching as well. And that's what I do from day to day. I sort of do 50% teaching and 50% clinical work over my working week. I work at the biggest publicly funded sexual health service in Victoria, which is owned by one of the big hospitals, Alfred Health. And again, we provide, I think, and it's not due to me, it's due to the leaders in the clinic. We provide a very good service. The clinic functions well, and on a very basic level. It doesn't have to be really sophisticated, but you can provide a very good service that feels rewarding, and the patients get a good service. And it's often very marginalised patients. And I think that's what I enjoy most of all, feeling that you can actually contribute to people's lives in that way. So in a sexual health service, the marginalisation is from the aspect of socioeconomic marginalisation, maybe marginalised because of their sexuality, maybe marginalised because they're from a different country and a different culture and they don't understand the service. So a good service in sexual health is one that is accessible to all of those marginalised people. And it's really great to be in a service that you feel you offer an equal service to all of those people who might find it difficult to access other services. So that's what I do, and that's how I teach. And I think I was just thinking the most challenging work that I've done. I worked in Indigenous in Alice Springs, in fact, in Australia, when many years ago when I came to Australia first. And that in a sexual health service in Alice Springs and in a primary care service in Alice Springs, dealing, well, they were Indigenous services, so only Indigenous people. And that was exciting and rewarding, but very challenging as well. And I think now, sort of 20 years later, probably it's still as challenging. Many high rates of STIs, high rates of poor reproductive health outcomes, mainly because of poor access to services. So not enough services are accessible for Indigenous people, and I think that's still much the same. But so very challenging, but exciting and rewarding. Yeah, and overall, I feel very lucky that I've been able to find work that combines clinical and public health and education all together. And yeah, I'm very lucky. Yeah. So I think we have to divide this question into two parts. So first of all, unplanned pregnancies in teenagers, the rates are decreasing. So it's not perfect, but it's much better than it was. In the 1970s, for example, and into the 80s, we saw very high rates of unplanned pregnancies in teenagers in many developed countries, so the UK, America and Australia. But over the last sort of 20 years, we've seen those numbers decline, which has been fantastic news. And I think at the moment in Australia, the rates that we're talking about for unplanned births in teenagers, or births in teenagers, is about 10 per 1,000 women between the age of 15 and 19. And it was about 50 so it had in the 1970s. So it has decreased dramatically. And there are probably many reasons for that. But one of the reasons that is important to remember, and which we can actually have an effect on is the increase in uptake of effective contraceptive services. So I'm sure many of your listeners will have heard of LARCs, which are long-acting reversible contraception methods. And that includes things like the intrauterine device and the hormonal intrauterine device, Mirena, and also Implanon, the implant. And they are very effective in preventing pregnancy in young people particularly. And because of the increasing uptake of those, that's one of the main reasons that we've probably seen reducing rates of teenage pregnancy, which is good news. And I think there's been increasing awareness, particularly in Australia, about the need to deliver accessible services to young people where they can get provision of effective contraception. And that's been one of the main reasons, I think, for the declining rate in pregnancies. In the UK, they had a fantastic teenage pregnancy strategy in the early 2000s, which saw a sort of more than 60% reduction in teenage conceptions. And that was partly due to accessible services, but also to do with the delivery of effective sexual and reproductive health education, which I know we're going to talk about a bit later. So I think unplanned pregnancies in teenagers is improving in Australia. And we just need to be able to roll out more accessible services to improve that even more with regards to the access to long-acting contraceptive methods. STI is a different thing altogether, I think, in many ways. We know that the rates of STIs are dependent on three major factors, and those factors are the duration of infection, partner change between individuals, and the transmissibility of STIs, which comes down to things like safer sexual practices and condom usage. Now, what's happened in the last sort of decade or so is we have seen a change in sexual behaviour, which has probably partially been fueled by online apps such as Grindr and other ways to meet people over the internet. And that has probably fueled unsafer sexual behaviours. We know that probably less condoms are being used, and we know that unprotected sexual intercourse is happening more amongst many groups in the population, young people, but also men who have sex with men and other individuals. So there's greater mixing of populations because of these internet applications, and there's probably more unsafe sex happening as well. So STI rates are an issue and are increasing. In young people, it's mainly about chlamydia. Chlamydia is the most common bacterial STI in young people. And that's easily transmitted if unprotected sex occurs. It can be prevented with a condom. It can be treated easily, diagnosed easily, and you can get rid of it. But you can get reinfected, and it's relatively common. Now, the problem with chlamydia is it can go on to cause infertility and long-term problems in women. So it's a very important STI, and we know STI rates are increasing in many groups in Australia. And at the moment in Melbourne, we have increasing rates of gonorrhea, syphilis, and chlamydia. Chlamydia is the one that's mainly associated with young people, but we are seeing increasing rates of gonorrhea and syphilis as well. So the major way that is best tackled is to improve access to services. We need to reduce the length of time people are infectious with their STI, and access to clinical services is so important. So we need to make services more accessible to young people, and there's various ways that can be done. So they do have benefits. We know there are well-proven benefits from sexuality education, but the sexuality education has to be of a certain standard. So there are now guidelines which have been endorsed by the WHO around the sort of sex ed that needs to be in place in order to be effective. And when we say effective, what we want sex ed to do is to reduce risky behaviours. We're not we're not at the stage like we were in the 80s and 90s when people were promoting abstinence only before marriage, particularly in America. We know that doesn't work. So the sort of global community has now accepted that in order for sexuality education to be effective, there are certain guidelines that need to be fulfilled. And those include things like the sex ed programs being comprehensive, inclusive, and so you keep everybody engaged. So we mustn't make it heteronormative, for example. We need to include people with different sexualities, different maybe transgender individuals. We mustn't exclude people. We must keep people engaged, because it's those most marginalized through programs that don't include them who will be most at risk of STIs. We know that these programs need to continue on a regular basis. The standards need to be monitored. They need to be medically and clinically factual. The people who provide those educational services need to be trained. And there's a lot of discussion as to whether it's best to have outside educators in the classroom or teachers who are trained specifically around sex ed. And many people believe that it should be the teachers delivering this, but they need to have training and resources in order to deliver that. We know that sex ed programs need to deliver core values, and these core values are about equity, inclusion, and mutual respect. It's not just about the biology of STIs. And we know that for these programs to be effective, we need to develop partnerships between schools and families and parents and carers, and it needs to be a whole school approach. So if all of those aspects are met in sexuality education, then the programs can be very effective in reducing risky behaviours, trying to increase the age of first sexual intercourse. We know that very early sexual intercourse between individuals is a risk factor and puts those young people at risk of poor reproductive health outcomes. And many times those are episodes which are regretted later on. So sex ed delivered correctly and as an appropriate educational tool can reduce risky behaviours and increase the age of first intercourse, which are both important criteria to aim for in delivering these programs. So the important vaccine to talk about is the vaccine for HPV, human papillomavirus. And that's a vaccine that is available and is given in many countries now as part of the sort of school program. So, and it's called, the name is Gardasil for HPV. And there's one now which is against 9 different types of the HPV virus. So it's called non-valent. It has 9, it is effective in preventing infection with 9 different strains of HPV. And that HPV, some of those strains are associated with cervical cancer in women. But some of those strains are also associated with men and women getting genital warts, and also some other cancers such as mouth cancer and head and neck cancers are associated with those HPV types. So that vaccine has been shown to not only reduce cervical cancer and cervical changes in women, reducing the number of genital warts in men and women. And Australia was one of the first countries to put that into their normal vaccine schedule for boys and girls. So now in Australia, boys and girls get HPV vaccine or are offered HPV vaccine in about year 8 at school, in high school. So that's at about the age of 13 or 14, I think. And that is ideally given before sexual activity begins. So it needs to be given sort of pre the initiation of sexual contacts to have its most maximal effect in preventing the transmission of HPV. And that's had huge effects. So that's a really effective vaccine, and that's available in most countries now worldwide. There are also vaccines for hepatitis B and hepatitis A. Now, Hep B and Hep A, Hep B, if we start with Hep B, that's a bloodborne virus, but it can also be transmitted through sexual intercourse. And that is given to all babies at birth in Australia. And it's also given in catch-up programs throughout school and in most countries of the world. So that's a really important vaccine because hepatitis B is not a very nice illness to have, although the majority of people recover. Some people don't manage to get rid of the virus completely. And if they have the virus for many years and decades, they are at risk of liver cancer later on. So a very important vaccine, which we can include in the STI vaccines really, because although Hep B is called a bloodborne virus, it's also transmitted sexually. And Hep A is also transmitted sexually amongst men who have sex with men or heterosexual couples who have anal intercourse. And Hep A, although it's not seen as a sexually transmitted infection, it is important in reducing Hep A amongst, as I say, certain groups who engage in anal sex. So that's also available. But there aren't any other vaccines for STIs at the moment, and it's a good question as to why aren't there. I don't really know the answer to why there aren't. There are lots of people, very clever people throughout the world working on vaccines, particularly, I would say, watch this space for herpes and gonorrhea. There are vaccines being looked at for those 2 infections. Now, herpes, people have talked about a vaccine for as long as I can remember, so 35 years or so since I've been working in the area. Every conference you go to, they talk about a new possible vaccine for herpes, and it's always been on the brink of coming out. They haven't managed to get it, but it's nearly there, I think. So I don't know when that will be available, but I think one day it's probably likely. And also gonorrhea one day. Gonorrhea is a real problem because it is evolving and mutating to become resistant to all antibiotics that we've got at the moment. So a vaccine would be a really good way ahead for that. So I think watch this space. We may get one for gonorrhea. We may get one for herpes at some stage. And HIV, people are talking about preventative vaccines. We have prevention with regards to HIV with PrEP, with medication, and there are lots of new ways that people are looking at delivering PrEP. So in injection or in implants, which would prevent HIV acquisition. So I think there are difficulties on a sort of molecular and technical level. I don't really know about them all in detail, but I think we will see some changes in the next 10 years, hopefully, with regards to vaccine development. And I think that's probably one of the major ways that STIs will be ultimately controlled is through vaccine development. So a very crucial point and a great question.